Good evening, everyone. So my next video is on the topic chelating agents. And before I start my video, I want to request you, if this video is useful to you and if it is helpful to you, kindly subscribe to my YouTube channel. This is Dr. Nitika Pharmacology Discussion. And now I'm going to discuss with you on the topic chelating agents such as heavy metal antagonists. Now, chelating agents, what are the chelating agents? Means whenever in our body there is heavy metal poisoning, these compounds, they make the complex with the heavy metals, and these complexes get excreted down. They form the stable non-toxic complexes, and these get excreted outside in the urine. These are the drugs which complex the metal ions, and they form a ring structures within their molecule. That is child crab. The compounds hold the metal like a crab's claw, and they primarily use the heavy metal poisonings. Heavy metals like arsenic, tin, lead, bismuth, copper, gold, cadmium, iron. All these heavy metals, we use the chelating agents. These chelating agents form a ring structure with these heavy metals, and then they form a crab's claw-like structure. So these compounds, they form the stable, non-toxic and easily excretable complexes with heavy metals, and thus these are valuable in poisonings. The ligands. What are ligands? These are the reactive groups which hold the metal ion forming a ring. Because these are the biological molecules in our body. These are the reactive groups, and they form the metal ion forming a ring. The metal ion is held at least from two sides. The coordinate bond is formed between the ligand and the metal ion. The shared electrons are donated by oxygen, nitrogen, sulfur atom of the hydroxyl, keto, disulfide amino or phosphate group. The heavy metals exert the toxic effects by forming complexes with these various biomolecules. Means they form the toxic effects. They are come when these ligands or the biological molecules, they complex with the heavy metals. They form the toxic effects, and these in the body interfering with their functioning, and they interfere with these with the function, form a ring-like structure with these biological molecules, such as these ligands. And these chelating agents, they compete with these biomolecules, forming complexes with toxic metal. The chelating agents, they will compete with these biomolecules, forming complexes with the toxic metal. All chelating agents should have higher affinity than the body ligand for the toxic metal. Means they should have the higher affinity for the heavy metal, for toxic metal, than the body ligand. Means if the chelating agent will combine with the metal, then they will form the stable, non-toxic, excretable complexes and will be excreted down. But if the heavy metal will combine with the body ligand, then toxic effects will come. Efficacy of all the chelating agents declines if the interval between time of administration and the ingestion of the toxic drug lapses and is prolonged. This efficacy will decline if the ingestion of the heavy metal and the administration of the chelating agent, that is administration of the chelating agent and ingestion of the toxic drug, is more or it is prolonged. Now, chelating agents used are British anti-lewisite dimercaprol, which is the main chelating agents used for most of the heavy metals like bismuth, lead, tin, arsenic, dimercaprosuccinic acid, succimer, disodium acetate, calcium disodium acetate, calcium disodium DTPA, penicillamine, desproxamine, and defidipron. Now, dimercaprol, which is British anti-lewisite, this was discovered in World War II, and it was the antidote for the poisonous arsenical gas, which was lewisite. So, just as it was the antidote for the poisonous arsenical gas, which is also known as the British anti-lewisite. Now, so it is the oily, pungent smelling viscous liquid, and the two sulfhydryl groups of the dimercaprol bind those metals, which produces their toxicity by interacting with sulfhydryl containing enzymes in the body. That is they have the sulfhydryl groups in the structure dimercaprol, and it will bind with the heavy metals. And this complex of the two molecules of dimer captor with one metal ion is more stable than 1:1 complex. Means they form the 2:1 complex. Means two molecules of dimer captor and one molecule of the heavy metal. It forms the stable complex. And it can be used in the mercury and arsenic poisoning. It can be used in the arsenic, mercury, gold, bismuth, tin, lead poisoning, and it is administered IM 5 milligram per kg stat, which is immediately followed by 2 to 3 milligram per kg every 4 to 8 hours and once or twice a day for 10 days. And it can be used as the adjuvant to the calcium so disodium agitate in lead poisoning. It can be used as the adjuvant to penicillamine in copper poisoning and Wilson's disease. Side effects are rise in BP, tachycardia, vomiting, tingling, burning sensations, inflammation of mucous membrane, sweating, cramps, headache, and anxiety. Next is dimer-captosuccinic acid or succimer. It is the structural analog of the dimer-captor and it is more orally effective. Dimer-captor was intramuscularly given. It is orally effective succimer and it is less toxic and more water soluble and just more specific for lead-chelation and it has no combination with agitate calcium disodium. Means it is not used as the adjuvant for the calcium disodium agitate. And the dose for lead chelation is 10 milligram per kg, every 8 hours, followed by 10 milligram per kg every 12 hours for 14 days. Uses, it can be used in the decreasing the toxicity of mercury, that is from the mercury chloride in the brain. In the brain, it is used as the antagonist in the brain for the mercury, succimer. And also, it also reduces the contents in the kidney, which is the key target organ of accumulation of mercury salts. So it also reduces the mercury contents in the kidney. And it is more suitable for treating lead poisoning in children. Side effects, anorexia, that is loss of appetite, vomiting, diarrhea, rashes, elevation of liver amino transferase enzymes. Disodium agitate is the disodium salt of ethylene diamine tetraesteric acid and it is the calcium chelator. So it can cause hypocalcemia on IV injection. It can cause tetany and it is used in the emergency control of the hypercalcemia. Calcium disodium agitate is the calcium chelate of disodium EDTA. It is the chelating agent for lead, zinc, cadmium, mercury, copper, and some other radioactive metals. And as it has the calcium in its structure, it will remove those heavy metals from the body and replace it with the calcium. And it is highly ionized, distributed only extracellularly and rapidly excreted in urine by glomerular filtration carrying the toxic matter along. Means as it is highly ionized, it will not cross the biological membranes. So it is present extracellularly and is easily excreted by glomerular filtration, carrying the toxic matter along. Uses lead poisoning. It can be used in iron, zinc, copper, manganese, and radioactive metals, but not mercury poisoning because mercury is more firmly bound to body constituents and is localized in areas not accessible to calcium disodium ATTA. Means the areas which are not accessible to calcium disodium ATTA and which are having the firm bound of to the body constituents, the mercury. As mercury is firmly bound to the body constituents, so it is not used in the mercury poisoning. It can be used in the lead, iron, zinc, copper, and manganese poisoning. Adverse effects, kidney damage with proximal tubular necrosis can be minimized by maintaining high urine flow. It can cause calcium disodium agitate, can cause kidney damage, febrile chills, body ache, malaise, tiredness, anaphylactoid reactions with fall in BP, congestion of eyes and nose. Calcium disodium DTPA. DTPA is diethylene triamine pentaesteric acid. It is the congener of EDTA. It is also the calcium chelate and it is used for heavy metals, especially plutonium and uranium. Limited distribution in body and uses restricted. This is used for heavy metal poisoning like uranium and plutonium, calcium disodium DTPA. Penicillamine, its D isomer is used therapeutically. It has a strong copper chelating property. Dimethyl cysteine degradation production of penicillin. And this is educatedly absorbed, orally administered, excreted in urine and feces. Uses, it can be used in the Wilson's disease. In Wilson's disease, what we have is there is a deficiency of ceruloplasmin, and it is the protein which disposes of copper from the body, which finds and disposes of copper from the body. When this deficiency of ceruloplasmin in the body, copper will be accumulated in brain, in the liver, and it will cause the in the substantia nigra and in the basal ganglia of the brain, and it will cause local degeneration. So it can cause hepatolenticular degeneration. So to chelate copper metal from the body, we have the penicillamine. Copper or metal poisoning, chronic lead poisoning, cystinuria, cystine stones also, penicillamine can be used as it combined with the cystine stones. In scleroderma also. Side effects, cutaneous reactions can occur, itching, febrile episodes, long-term use may produce toxicity. Dermatological, renal, hematological, collagen tissue toxicities are prominent. Desproxamine, Proxamine is the long-chain iron-containing complex obtained from the actinomycin. Means this is the iron-containing complex, and when we chemically remove the iron from this structure, which is obtained from the actinomycin, we get desproxamine, and this desproxamine has high affinity for iron. 1 gram is capable of chelating 85 milligram of elemental iron. And the straight chain desproxamine molecule binds around ferric iron and forms a stable non-toxic complex excreted in urine. It removes loosely bound iron as well as that from the hemosiderin and ferritin. It also removes the loosely bound iron as well as from the hemosiderin and ferritin, but not from hemoglobin and cytochrome. Another desirable property is low affinity for calcium. It has also the low affinity for calcium. It can be used in acute iron poisoning, like when the patient iron sulfate tablets, iron gluconate, fumarate tablets has been taken by the children for the iron deficiency. So we can give in the acute iron poisoning. It may be life-saving, and in transfusion cirrhosis, like in thalassemia patients, when repeated blood transfusions are given, there can be chronic iron overload in the body, which can be treated by this desproxamine 0.1 to 0.5 to 1 milligram, gram per day IM helps to treat chronic iron overload, may be infused IV also concurrently with blood transfusion 2 gram per unit of blood. Adverse effects are it causes histamine release, so it will cause fall in BP, flushing, itching, urticaria, rashes. It can cause change in lens and retina, can occur on repeated use. Abdominal pain, loose motions, muscle cramps, fever, dysuria, difficulty in urination. Deferriprone, it is the orally active iron chelator, and it has been used for transfusion cirrhosis in thalassemia patients. Like excessive hemolysis can occur in these patients, and they have to be given repeated blood transfusions. So, so we give this when there is chronic iron overload, we can give the deferriprone to treat chronic iron overload in these patients. And oral deferriprone is somewhat less effective alternative to the injected desproxamine. Deferriprone has been indicated for acute iron poisoning and for iron load in liver cirrhosis also. Because when there's iron load in liver cirrhosis and when there's acute iron poisoning, when the patients take iron tablets, then in that case also we can give deferriprone. Side effects are loss of appetite, vomiting, altered taste, joint pain, reversible neutropenia, agranulocytosis. So that's all with the chelating agents. I hope you understood this video. And if you like this video and if this is helpful to you, kindly subscribe to my YouTube channel. This is Dr. Ritika Pharmacology Discussion. Thank you. Be happy, be healthy, be blessed, be safe, be blessed. Thank you.